Okay, we move to the next speaker. He is the expert for the epilepsy surgery. Professor Sarat Chandra will be speak about recent advance in epilepsy surgery. Please, Prof. Sarat, you can start the presentation.
Thank you so much. It's been a pleasure listening to Harry's talk. And let me just go back to my slides. And I'm at the outset, I'd like to extend my sense of gratitude to the entire organizing committee for having organized this very important webinar. Because this is a topic which is not often discussed in the neurology and neurosurgical circles. And epilepsy surgery is something which is not available in every neurosurgical center. And hence, there is a need for this to be developed in every neurosurgical center. But again, this has to be performed in a very graded manner. And it's very important to develop the expertise, training, as well as the entire system in a very, very systematic manner, just as Dr. Harry has been doing in Surabaya. So at the outset, this is our entire clinical epilepsy surgery team. We also have a full-fledged research team, and we were very happy to have Harry with us as a fellow. I'm also particularly happy that he's able to start a very good epilepsy surgery program in Surabaya. So now on the top, if I will first, Harry has already spoken about the basics of epilepsy surgery, and I will try to take you to a more complex stuff to make you understand of what could be the entire spectrum for management of epilepsy surgery and what are the facilities available for managing higher level of complexities. Now on the top, what I'm showing you is something which is not happening nowadays. It shows because of the COVID-19, it shows the flight paths of all the airplanes all over the world. And if you see the flight paths, majority of the flight paths, they take off from US and then they come to Europe and maybe some to UAE. So the way the flight paths are structured is that they would first start from a distant place and then go to a hub. And from the hub, they would be connected to another major hub and then they go to more distant places. And if you were to imagine the neurons in the brain would not be randomly connected, because if it were so, it would occupy 50% of body's metabolism. So that is the reason to believe that there would be some kind of a structure for the neurons to be connected. And in this manner, when we think of epileptogenic networks or epileptogenic connections, we think that there are nodes in various areas, and most of the seizures would be propagated through these nodes. And this is the recent aspect of thinking about epilepsy surgery. So unlike our previous belief, where we used to think that a focus is static, it is single, it is absolutely of the same size over a period of time. In networks, we believe that it could be dynamic, which means it changes over a period of time. It could be multiple, and it could be expanding over a period of time. So it's not a static. So we have done close to 3,000 cases till now, and this I have to upgrade this slide. But we have established the Center of Excellence for Epilepsy, and the basic idea of establishing this center is to study epileptogenesis by using epileptogenic networks, and also to identify potential biomarkers which could be used as a mechanism of cure for epilepsy surgery. And we have a magnetoencephalographic center, full-fledged clinical electrophysiology lab, and we also have a neurobiology lab where we are able to study the cell samples, and we are able to do electrophysiological studies on the receptor brain tissues. And the study of these electrophysiological samples are on live brain tissues. So that is why they have to be transported within a period of 15 to 20 minutes as soon as the surgery is over. So this is some of the research papers that we have published, where we have shown for the first time the role of endogenous NMDA receptors in the transmission of epilepsy. And in this interesting paper, which has a translational value, we have shown that particularly in mesial temporal sclerosis, more than the hippocampus, the extra hippocampal circuits are very important. And again, this brings us to the conclusion, which has been existing in the clinical setup for some time, stating that when we need a better seizure outcome, especially for patients with mesial temporal sclerosis, we need to do a wider resection, which includes the temporal lobe apart from the hippocampus also, because the majority of the circuits could actually be outside the hippocampus. Few more papers. For instance, this is an interesting paper where we have done electrophysiological cellular studies comparing pediatric and adult cortical dysplasias. And we have shown that in pediatric cortical dysplasia, the spread of the epileptogenic neurons is much more wider, and hence a much more bigger resection may be required in pediatric as compared to adult cortical dysplasias, where a seizure freedom may be obtained by doing a more focal resections. Now, like Dr. Harry has explained, we have perhaps two modalities of surgeries. One is, we will imagine that a particular chip is epileptogenic, so we could actually resect it, and this is called as resective surgery. Or we could disconnect it from the surrounding areas, and we could call it disconnective surgery. And the third mechanism is, we could do some kind of neuromodulation. So as of now, these are the only three modalities of epilepsy surgeries which is available in the entire spectrum. We don't have a fourth modality of surgery. And based on what type of surgeries we can do, these are some of the examples. So the temporal lobe surgery, what Harry has shown, is a receptive surgery. And in disconnective surgery, we could have hemispherotomy or a corpus callosotomy or even a TPO disconnection. So like Dr. Manjari has mentioned, if a patient fails 2 drugs, that is when the chance of him failing or succeeding on the third drug is less than 1%. So by and large, if a patient fails 2 drugs, we kind of think that this patient has drug-resistant epilepsy. But like Dr. Manjari has mentioned, these drugs should be applied in its optimal combination and its optimal dosage. Now, in children, it's very important that we consider surgery as early as possible, because they are prone to a much more serious complication, which is called as epileptic encephalopathy. So the brains can actually shrink very fast, and there could be a very severe cognitive delay on in children if we do not subject them to surgery as early as possible. Now, this was a landmark paper which we published in NEGM, which is only the third randomized controlled trial after Weeb's and Prof. Jerome Engel's trial, where we have shown that in children, the efficacy of surgery is about 10 times more than when they are subjected to only medical therapy. And apart from that, it's very important for us to consider surgery much more earlier in children, because if we delay surgery, then the likelihood of these children having cognitive worse outcomes is much more. And hence that becomes a second more important reason to perform surgery in children as early as possible. Now, in this paper, like Dr. Manjari has told earlier, in this study, we have shown that whenever a patient has a structural cerebral abnormality and non-responsiveness to the first anti-epileptic drug, these are the 2 high-risk indicators that these patients should be worked up for epilepsy surgery much more earlier than being provided a trial of medical treatment for longer time. And apart from that, of course, the other factors are also important to consider surgery, but this would be the 2 most important factors to be considered for surgery. Now, before starting an epilepsy program, this was exactly the question which even Harry asked me, that we do not have all facilities, how should we start an epilepsy surgery program? It is very important to understand that in order to start 60 to 70% of your epilepsy surgery program, all you require is a very good video EEG and a MRI where you have a dedicated neuroradiologist who will be able to help you out with the scans, especially to identify the subtle pathologies like focal cortical dysplasias. And of course, later on, you could add the other facilities what we have here. It's nice to add the other facilities, but they add up maybe 30% and then 10% of rest of the diagnosis, and they should be there in one tertiary center. The reason we need to have different kinds of investigative modalities is that we have to understand that epilepsy is not a static process like a tumor growth. So if you see a tumor on MRI, it's more or less static. It takes months to grow. Epilepsy is a highly dynamic process which changes within seconds. And we do not have any kind of a video recording machine. We just have snapshots or photographs. And each of this snapshot or investigation has a different temporal resolution and a different spatial resolution. And this is the reason in complex epileptogenic networks, we need to have more than just a video EEG or an MRI. We need to have a SPECT, we need to have a PET, and sometimes we need a magnetoencephalography, and still we are not able to get any kind of results, then we may have to go in for an SEEG or for intraoperative electrocardiography and so on. The idea is we still do not have an ideal investigation which could be of the highest temporal resolution and can cover the whole brain. We don't have anything like that. And in absence of that, we have to do an intelligent combination of all these investigations, just as we would do an intelligent combination of all the medical therapies before trying to treat them medically. Now, this is the kind of pattern we follow. I know it looks a bit confusing, but it is not. So every patient needs to undergo an epilepsy protocol MRI. And if it is negative, we would like to repeat the MRI, because most often the patient comes with MRI films from outside. And I would not recommend you to give a decision on epilepsy surgery based on films. It's better to ask the patient to bring the CD, and the kind of MRI which should be done is thin slices MRI, and you should examine the MRI on a CD, on a computer, or on a digital format rather than on the films. And then of course every patient has to undergo a video EEG. Now here you should be able to get some kind of information practically 60 to 70% of the patients. Now if you have a PET or an ictal SPECT, it's very good to do it. And if you have a magnetoencephalography, it can again be very, very useful for you to provide more information. Now this was an important paper which we published, where we did a concordance study between ictal SPECT and PET, and we found that it was particularly useful for extratemporal surgeries. So if you're thinking of doing a temporal surgery, the concordance or for having a SPECT or PET is not so useful, but definitely when you're thinking of an extratemporal surgery, having a ictal SPECT and PET would be very useful. And if you have a concordance between both of them, you would be perhaps be able to avoid an invasive EEG. And the reason is that we thought in this study, we thought that in extratemporal, the epileptogenic networks are slower with the surrounding tissues. So that is why if you have a concordance of ictal SPECT and PET, you could have a much more better idea of localizing the epileptogenic focus. Now we have a magnetoencephalography which is located about 30 kilometers away from AIIMS, because in AIIMS we did not have the space to put up the MEG, and it's in a place called National Brain Research Center, which is a research center. And over years we have been able to develop more and more complex protocols in order to localize the epileptogenic focus. And these are some of our papers which we have published. Now, what are the conditions where we need to consider neuromodulation, which includes VNS? Now, when we consider vagal nerve stimulation, many surgeons have a tendency to overdo vagal nerve stimulation because it's a relatively simple procedure to be performed, where you put a battery-like generator over the left side of the chest and connect it to the vagus nerve, because it's an extracranial procedure. But what is important to understand that every patient, before he or she is subjected to VNS, a proper complete investigation has to be done so that we rule out any kind of a resective or a disconnective surgery. Because by and large, resective or disconnective surgeries have much more better outcomes than doing a VNS. Only when we rule out any kind of a surgical substrate, like here is shown, if you have a patient with mesial temporal sclerosis, one should never even think of doing a VNS. But if you have ruled out a temporal etiology or an extratemporal etiology, and we don't have any kind of lesion seen anywhere, that is when we should go in for a neuromodulation procedure like a VNS. And in many centers, I would also say that you should go and perform an stereoencephalography or an invasive EEG to actually also rule out. But the issue is it becomes very expensive for many centers. So if your neurologist is reasonably sure that there is no focus anywhere, and you have done all the advanced investigations to rule out any kind of a focus, that is where you could go in for a neuromodulatory procedure like a vagal nerve stimulation. Now, more recently, if we have a lesion over the eloquent cortex, people have been considering RNS, but however, RNS is not available both in India and Indonesia, and currently it's only available in the US. So we do not have any experience with RNS. Now, in terms of recent surgical strategies, there have been many techniques by which we have been improving the surgical outcome. And these are the various headings in which I will flow you around. And many of them are not just recent techniques, but I would like to kind of give you an overall education on how important it is to identify the epileptogenic networks. So when a patient comes to even our center, the lesion pickup rate is initially 40%. And even if the report says that the patient is MRI negative, we end up doing a repeat MRI because we understand that most of the substrates in epilepsy surgery could be very subtle. And that is why you need to discuss this MRI in an epilepsy surgery meeting, where you can again discuss with your neurologist, with your neuroradiologist, with your nuclear medicine, and so on. Now, in about 20% of the patients, you could do a more advanced investigations like a PET MRI fusion, and you find a large area of hypometabolism, and then you go back, and then suddenly you'll find something abnormal. So there could be a retrospective relooking of the investigation in approximately 20% of the cases. So that is why it's very important that even if an MRI is negative, it is important not to give up, and you should always go back and recheck the MRI. And if you want to repeat the MRI, do not be shy of repeating the MRI, because when you repeat with a thin slice, you could always end up finding something new. Now, intraoperative MRI is a very expensive tool. We ourselves have it, but over years have kind of stopped using it, especially when we have neuronavigation. We have very good preoperative localizing tools, and we also have advent of stereoencephalography. That is when we have started using neuronavigation less and less. But in this study, which we have done about some years ago, we have identified that it was very useful in performing complete resection of focal cortical dysplasias. But our focal cortical dysplasias now are guided more with electrocorticography rather than with intraoperative MRIs. Now, using multimodal imaging is a very good way to go forward. And if you have capability of doing multimodal imaging, where you can fuse various technologies like MRI, PET, ictal SPECT, as well as electrocorticography, you would get a better idea of performing an intraoperative localization. Next tool, which is not actually mentioned very much by surgeons from US or from Europe, but has been a very good tool in our own setting, is electrocorticography, especially intraoperative electrocorticography. Currently, we have more than 1,500 cases of experience of intraoperative electrocorticography, and we do intraoperative electrocorticography in practically every case. And we have found it very, very useful, especially when you can have an optimal pre-anesthetic protocols for eliciting good intraoperative electrocorticography. And we use a grading system, and we do multiple electrocorticographies even post-op, especially for focal cortical dysplasias. So we can have such an abnormal score, and we have this lesion mapped out, this area mapped out. And when we do resection up to here, it has normalized. But when we do a more wider resection, it becomes normal or score 1. So we use electrocorticography multiple post-operative times, and we have found this strategy especially useful for focal cortical dysplasia. And in all the focal cortical dysplasias, especially the type 1, and some cases of most of the pediatric cases, we find that we have to perform a resection which is much more larger than the anatomical focal cortical dysplasia, and it was practically not possible for us to just limit it to one particular area. Now, another modality which has been coming up in recent years and has practically replaced the intraoperative grids and strips in our center, where we do not do intraoperative strips and grids anymore, is stereoencephalography. Now, as you know, stereoencephalography has been developed by Telerak and Boncon, and it has been around for since many decades. But over a period of time, currently it has evolved much more, and it is globally accepted for the reason because when we combine it with preoperative investigations, especially the more advanced investigations like ictal SPECT and PET, we are able to get a much more better idea of how to localize the networks, and we are able to do resections which are much more accurate. So we don't have to do such extensive stereoencephalography, what has been originally described by Telerak. Now, this could be the various indications of SEEG. First is to verify a network. So if you have a very subtle lesion which is not very much apparent on MRI and you would like to confirm it, that is when you could do an SEEG. Or there could be situations where you have a non-concordance between video EEG or MRI or PET, and you would like to have some degree of concordance. That is when again you could do an SEG. SEG is particularly very useful for multiple lesions. For instance, bilateral MTS or in tuberous sclerosis, where more advanced investigations like PET MRI fusion has not been useful. That is when again SEG could be useful. Or you want to find out a lesion when it is completely MRI negative. Now this is actually very difficult, even though technically it may sound easy that yes, uh, SEG is very useful to detect a lesion when everything is MRI negative, but it's actually very difficult. And now this is how the SEG looks like. As you can see, it's very minimally invasive as compared to intraoperative grids. And these are the advantages of SEG as compared to the grids. Currently, we are actually doing everything using only SEG because we are able to understand better anatomically, and the resection also has become much more better to understand when we are doing the SEG. So the main advantages of SEG is that the electrodes are very thin, excellent recordings. Most important and most useful for me is that the explantation is very useful, especially in the ICU. We don't have to take up the patient again for surgery. We've also found it very useful for language mapping, which at one time we used to think is a disadvantage for an SEG. And the only issue is that we have to do it with a robotic system. Now again, this is not mandatory. If you have to only implant, you can also use a stereotactic atlas. Only thing is it takes a little bit more of time. But if you have a robot, definitely it's more expensive, but it's definitely an advantage. And the complications of SEGs is definitely much more less than for invasive grids and strips. So this is how we do. This is a workflow we have. We have a O-arm as well as a robotic device, and these are the instruments which we use. And this is a video which has been prepared by Harry. I can briefly show it. So we don't give stab incisions anymore. We carry the sleeve forward and drill it directly. So once we tighten the so we fuse the O-arm with the robotic trajectory and then confirm. So the red is the robotic trajectory, and you can see the actual placement of the electrode. And this gives us a good idea that the electrode has been placed in a proper position. So these are the standard exploration patterns for SEGs, and we can of course modify them depending on case to case, but there are certain standard exploration areas, and again we can modify a bit depending on case to case. And we have a worksheet, we have a named the SEG worksheet where we decide the plan before surgery. Now it's important to understand it's not a fishing experience expedition. It doesn't mean that if somebody, once my student asked me that if I can place 100 electrodes, will I be able to know where the focus is? The answer is probably not, because when you're placing SEG, the standard number of electrodes which you place is anywhere between 7 to 10. But if you have crossed more than 15, let us say you're putting 15, 16, it's likely that you have lost the hypothesis. So having more number of electrodes doesn't actually mean that you are going to get more information. So that is why a good preoperative hypothesis is very, very important for you to have to understand where exactly you need to put the electrodes. Now, once we put in the electrode, we do the monitoring and we also do a stimulation. The stimulation could be a low frequency stimulation or a high frequency stimulation. These are the parameters we use for stimulation. And this is, we have a EEG machine where we can set the parameters on how we want to stimulate. Now, interpretation is most important. So that's where the role of neurologist comes. And these are the two most common mistakes which can happen when you're trying to interpret the SEG. For instance, you can have 3 SEG electrodes over here. So if there is a focus which is arising from an area which is completely distant, so it is an intrahemispheric distant focus. So this focus could come and go across over here. So if you put 3 electrodes here, you will end up thinking that this is the area which is epileptogenic, whereas in truth, it is much more separated away from this area. Similarly, if you have a focus coming from the opposite side, unless you are connected bilaterally, you will not understand that. And if you have same side electrodes, you may end up thinking that the focus is again on the same side, it's not coming from the opposite side. So it's always a good idea to put some kind of sentinel leads on the opposite side so that you could know what is the activity on the opposite hemisphere. So the example, let us start with some very simple cases. This patient was operated for a left mesial, for a anterior occipital neurocysticercosis. And when we did a video EEG, we found that most of the seizures were coming from left temporal lobe. So this was the area where the neurocysticercosis was removed, but now we were getting most of the activity from the temporal lobe. So in this case, we just put 2 electrodes, one within the occipital area where the neurocysticercosis was removed, and one within the temporal. And these are the seizures. I will skip the videos, but we could clearly see that the onset of seizures was from the left temporal lobe. And using this, now we were able to get a confirmation that we did a standard temporal resection. It turned out to be mesial temporal sclerosis, and the patient was seizure free. Now, this is another example of a 13-year-old female having seizures for the past 11 years, 40 to 50 per day. Underwent a resection for a right insular FCD elsewhere. And now you can see that there is a resection here. Patient has now come with 8 to 10 seizures a day, was seizure free for 1 year, and then started having seizures. The video EEG again showed activity from this area, and MEG again showed a spike from the same area. So in this case, we put electrodes. These are the electrodes which you put: this oblique insular, basifrontal, amygdalohippocampal, orthoinsular. These are the, so we could do with just 5 electrodes, and we put 1 sentinel on the opposite side. And we found that the orthoinsular was giving the seizures, and then we went ahead and resected the anterior part, and the patient was seizure free. So in this case, the SEG helped us to confirm the residual posterior insular FCD and its relevant networks. Now, this is a 22-year-old male who was having about 4 to 5 seizures per day. The problem was we were able to see that the patient had very nice focal cortical dysplasia, but it was located exactly on the Broca's area. and he was a high performing individual, and the parents were not at all ready to have any kind of language deficit. So they said, no, we need to have, because if he has a language deficit, he was doing his engineering course, so he would lose his studies, so they were not ready for that. So in this case, we did a fMRI, and we were able to find that language was seen bilaterally. So that gave us some sense of confidence that perhaps the language is not located to the left side. And we put about 7 electrodes all over the Broca's area. And we did see very good seizures coming from the cortical dysplasia, which was not unexpected because there was a very good lesion there. But more important, when we stimulated it, we found that there was absolutely no speech impairment. And this gave us a very good idea that this area was not sustaining speech. And we did intraoperative electrocardiography, and we did a good resection. And this is the patient post-operative. He had a good outcome. The video is not seen, but he had a good speech. He didn't have any impairment of speech. So in this case, the SEEG helped us to map the language and exclude the eloquence from the left opercular area. It gave us a very good confidence to go and do a wide resection. Then another example of a 28-year-old female who was having seizures since the age of 15 years, duration of seizures 13 years. Initially 1 to 3 per day, now 5 to 6 per week. And as you can see, the patient had practically, in the ictal spec showed that this was coming from the temporal area, which was confirmed with the MEG that it was left, but otherwise the MRI and PET did not show any kind of localization. So in this case, the semiology was left frontal and right temporal. The MRI left inferior and temporo-occipital. The PET showed hypometabolism bilateral anterior temporal, and the SYSCOM is left inferior temporal. And the MEG again showed left anterior temporal and right posterior temporal. So this is the way we construct where exactly we have to put the leads. So we thought at least we should do bilateral coverage here. So we did bilateral temporal origin of seizures with singular and bilateral insular. So we put left temporal 4, right temporal 3, left insular 2, right insular 2, bilateral cingulate. So we had a bet more on the left side, and we were able to clearly show the onset of seizures from the left side, the left basitemporal proceeding to amygdala. So finally, we decided that the SEEG stimulation also corresponded to left basitemporal and repetitive spikes from left amygdala. So finally, we decided to do a left neocortical resection with amygdalectomy, and we spared the hippocampus. The reason is when we put the SEEG leads, we didn't see any activity within the hippocampus. So in this case, the SEEG not only helped us to localize the area, but also helped us to spare the hippocampus, because neither did we see any activity from the hippocampus. And even when we produced a stimulation in the hippocampus, there was no production of habitual seizures. So these are the spontaneous seizures where we were able to generate the seizures. I will skip the video. Then these are the stimulation which showed the habitual seizures, and this was happening mostly from the posterior leads. Now, preoperatively, this is the superior temporal, this is the middle temporal gyrus. So we resected the temporal lobectomy, and after this, the ECOG became grade 3. And when we removed the amygdala, the ECOG became grade 1, and we were able to get very good recordings. So we spared the hippocampus. So here SEEG helped us to localize epilepsy to the left neotemporal and amygdala, and also left basitemporal. It helped us to spare the hippocampus, thus sparing the visual memory. So in that way, the SEEG was very useful for us. So few more examples of very complex cases. The 21-year-old female who was having about 1 seizures a day. Now in this case, the patient was having history of aura floaters. I think I will skip this. But here we were able to show, we put again electrodes. These are spontaneous seizures, deviation and head drops. Motor cortex stimulation did not show any seizures. So we were able to do a resection, and then this is how we localize the seizures intraoperatively. And we did an anterior angular gyrus resection and precuneus resection. And then we were able to do a large resection. This is a post-operative CT. So in this case, we were able to resect a very wide area of networks consisting of angular gyrus, lingula, precuneus, and posterior part of inferior temporal gyrus in a patient where the MRI was absolutely normal. So we do agree it was a very wide area of resection, but again, using the SEEG gave us a very good deal of confidence in order to in order to provide us that amount of confidence to remove a wide area of resection. So we have to remember again that SEEG is not a black and white phenomena. Yes, it does help us to increase the good outcomes, but again, it has to be done carefully. So I have shown you, and in our experience, we have replaced SEG completely for any other. So we don't use strips or grids anymore. Now, endoscopic techniques were first introduced by us for both hemispherotomy and corpus callosotomies, and we have published it in enough number of papers. And after we have described the technique of endoscopic hemispherotomy, I'm very happy that even Harry has started doing it, and world over, people have started doing this technique. So recently, we participated in the HOP study, which has a total of 1,267 hemispheric surgeries from 12 countries, and overall a 64% of class 1 outcome is seen, which is actually very good. So this is the open hemispherotomies. I will skip on hemispherotomies because I'm supposed to speak more on newer techniques. But the open technique has two types of techniques, which is vertical or lateral. And this is what I was doing more than a decade back. And after that, I shifted to an interhemispheric. And currently, I do an endoscopic interhemispheric. And when I developed it, it was as good as trying to pass a camel through eye of a needle, but now it's a standard procedure for all our hemispherotomies where we do an endoscopic techniques. And these are the papers which have been published. And these are also the chapters. It's a chapter in pediatric epilepsy book, which has been written by two huge institutes. August is from MIT and Jallo is from John Hopkins. The forward is by Mohammad Ghazi Asargal, and I've contributed 2 chapters, and I can see Harry's name in both the chapters, one on endoscopic assisted hemispherotomy and other on corpus callosotomy. And this is how we do the procedure using a robotic guidance with an endoscope. And there's a few examples of pre and post-op hemispherotomies, and we have done it for all kinds of pathologies. Even the most, this was a patient which I operated in Malaysia, patient having multiple seizures, hemimegalencephaly, and Harry was there with me for the surgery, and the patient is doing extremely well. Another very complex case of cortical dysplasia with hemispheric cortical dysplasia, and we did an hemispheric disconnection, and you can see the disconnection which has gone through here, and patient had a class 2 outcome. Again, you can see a very severe case of hemimegalencephaly. We did a hemispheric disconnection, and you can see the nice disconnection which has been done like this. So I will skip the procedure of endoscopic hemispherotomy because of lack of time, but it has become the standard procedure for all hemispherotomies. And when we do a long-term follow-up, now these patients will have de-efferentation atrophy. This should not be confused with hydrocephalus. So once the hemisphere is disconnected, most of these cases will undergo a de-efferentation atrophy. And in our experience, we have found that the outcome of hemispherotomy, endoscopic hemispherotomy, is same as open, including the cognitive outcome, but the blood loss as well as the post-operative stay is much lesser. And it has been quite even for adult hemispherotomies. Now, more recently, one of my fellows did this study, and we studied on how we can enhance the outcome. So our overall outcome was 80%, which is well above the global average. And we showed, we did in 8 cases where they did not have good seizure outcome, we did an MRI, and we found that there was a residual temporal stem. And once we removed the temporal stem, the outcome went up to 90%. And we have published this more recently in Journal of Neurosurgery, where we discussed the role of temporal stem causing residual connections. And this again has been described in the literature for the first time, because in Delalanded technique, nobody talks about the role of temporal stem. And here in this paper, we showed what exactly is the relation of the temporal stem, which is anterior to ventral amygdala. And if you have to do a repeat surgery, all you need to do is a straightforward disconnection. Now, in cases where there is still a residual connection, but the patient is seizure-free, as in this case of 2-year-old hemimegalencephaly, there is a residual connection, but the patient is seizure-free. We do not have to rush in and try to do disconnection. We can closely follow up. But in case patient does have recurrent seizures, it would be a very simple thing to put an endoscope through this cavity and do this disconnection. And the surgery should not take more than 15 to 20 minutes. So we have to understand that whether it's a lateral procedure or a vertical procedure, In a vertical procedure, the temporal stem is the deepest area, and hence there is a tendency for it to be left behind. And we should not call it as a failure, we should call it as a staging, meaning that if there is a residual temporal stem, there should be an opportunity for us to go back again and be able to do a repeat surgery. And it's very much possible when we are dealing with complex cases like hemimegalencephaly, where you do a staging stage surgery. I think it's pretty much safe enough. Similarly, when we do a lateral approach, we have to understand the deepest area is genu. For instance, this is a patient who underwent a lateral approach outside elsewhere in other center. So you can see that the surgeon was not able to approach the genu because that was the deepest area. You can see how much of genu is left. But this is the most superficial area if you do an endoscopic technique, because when we bring the endoscope, this is the first area which we meet here. So that is what we did. We did endoscopic disconnection of the area which was left behind in the lateral technique. And this was a patient from Nepal, and after which the patient became seizure free. So once we have described, now it's been taken up in various centers across the world, in the US as well as in Indonesia and Malaysia. So people are doing it more and more. So endoscopic hemispherotomy is a safe, effective, minimally invasive procedure for all types of pathologies. It has enhanced the success by addressing the temporal stem by 80 to 90%. So by reoperating on patients who had residual temporal stem, we were able to enhance our outcomes to about 90%. And the repeat surgery is actually simple. And I presented this at the ANS symposium, which was held in Santiago. We also described the endoscopic assisted corpus callosotomy for the first time. And we combined corpus callosotomy with anterior hippocampal and posterior commissurotomy for the first time in the literature based on our own study. And we have shown that whenever we combine it with the commissurotomy, the outcomes actually increase much more better. Now, finally, we come to the robotic guided lesioning, which you have applied to hypothalamic hamartomas. So in hypothalamic hamartomas, we know that we don't need much investigations except for doing an MRI and video EEG. We don't need much of other investigations to be done. It can be very easily diagnosed. And these patients, they present with, you can see this patient is having gelastic epilepsy. So the bursts of laughter which happens, and about 20% of the patients can present with precocious puberty. So there are various open techniques described, but again, they have very high mortality and morbidity. And that is why we developed the technique of robotic radiofrequency ablation. And this is to show how we do it. So we perform multiple burns with multiple trajectories. And the advantage of having a robotic device is that you can actually plan multiple trajectories. So we do an ROSA and OARM co-registration for only one trajectory. So that reduces the radiation. So this is just to show a few examples. For instance, this is a hypothalamic hamartoma here. So what we do is we do a radiofrequency ablative disconnection. So we burn the pedicle. We don't have to burn the entire hypothalamic hamartoma. And so we use 3 trajectories and 11 burns, and we were able to burn the whole thing. Now this was a patient who had a giant hypothalamic hamartoma. So we used 8 trajectories and 34 burns. There is no way that you could treat this even surgically. But using the robotic trajectories, we were able to treat the entire hypothalamic hamartoma. So was Harry here when we treated this? He was maybe, I think he must have just left. So again, we are using the OARM.
I'm still here, Prof.
You were there? Did you see this case?
Yeah, I'm still here, Prof.
Okay. No, I mean, when we operated this, did you see this case? Must have been done when you left, I think.
I was there for the first case.
First
not
case,
not
okay,
this one.
Okay.
I think this is the second surgery, I think.
No, this I think was 4th or 5th surgery, because it's a very complex case. So, so you can see that this is how we do. It's like doing the SEEG earlier. So I will not show that. But here, instead of introducing the SEEG electrode, we introduce the radiofrequency electrode, and then we burn. We take an OARM and we merge it with the pre-op MRI to show the trajectory is good. And we do it only for one trajectory. And then once we confirm that it's within the hamartoma, we burn it for about 74 degrees for 60 seconds using the Lexel's generator. This is not, unfortunately, this is not available anymore in the market, but it's an excellent generator. I don't know why they discontinued it. We have got the Cosman's generator, but we're not so happy as it is, as we were with this. And as you can see, we used about 34 burns with 8 trajectories, and we were able to obtain a complete cure. So we've done it for about 18 patients, and we are very happy using this technique. It's a minimally invasive technique. You can repeat it if you want it, and the repeat surgeries can be again done very easily. We published an initial paper here, and now we are publishing one more paper, which is going to come up in the next month. Now, finally, I will speak about neuromodulation. So neuromodulation, it's very important to understand that it should be considered like another drug. So the common neuromodulation procedure which is available everywhere is vagal nerve stimulation. So when you have to do a VNS, you have to think that all options for drug have run out. There is no possibility of doing surgical therapy. So you can do a VNS which will be like an extra lifeline. So when you're playing a video game, you have run out of all lifelines, and when you do a VNS, you get an extra lifeline, or it's like an extra drug. And if you have this kind of philosophy, you'll be able to accept the results of neuromodulation much better, because the results of neuromodulation, even though they are very good, they're not as good as receptive and disconnective surgeries. And these are the various types of targets which could be there for various neuronavigations, for neuromodulations. So VNS reduces seizures by more than 50% in 50% of the patients. That's the approximate benefit of VNS. And this has been shown in various studies. Similarly, it's also been shown to be quite effective in this PULSE, which is an open prospective randomized long-term effectiveness trial, where they have shown that it is also very beneficial over a long period of time. Now, the additional advantage of VNS is that it also improves the mood. And the way the VNS neuromodulation also improves is that there is a sustained benefit over a period of time. Now, more recently, they are introducing more complex forms of VNS, which I will not touch because of lack of time. Now, briefly about the DBS for epilepsy is now FDA approved. So it was part of a Santias trial. Now, this was one of the few cases which you have done. But currently, we don't prefer DBS. We prefer to do VNS because it's a simple extracranial procedure. In addition, VNS also improves the mood, whereas the DBS tend to bring down the mood. And since it's approved, we are more comfortable with the VNS, and our neurologist, Dr. Manjari, is more happy with VNS rather than DBS, which requires a complete surgery, but it's an option. Now, this was a Santias trial where it was shown to be superior than with just medical therapy. And initially, it was not FDA approved, but when they went back and reanalyzed the results, that is when it became FDA approved. Now, RNS is something which is not available both in India as well as Indonesia, and it's a very expensive device. I don't personally have an experience, but you could put the electrodes over the area. You need to have a very good localization here. But one of the important things about RNS, which are coming up when I'm discussing with my colleagues in the US, is that you could use it for seizures arising from eloquent areas where resection may not be a possibility, and you could do an RNS in such cases. Now, regarding outcomes, Harry has touched upon it. Now, this is one study which is very well quoted when we are thinking of outcomes, long-term outcomes in epilepsy surgery. But I will briefly show you that the overall outcomes, now we're talking of long-term outcomes over 10 years and so, and we can see is much, much better than giving medical therapy, because the chance of these patients improving with medical therapy is less than 1%. So that way, if you look at surgery, these are the class 1 outcomes, which is actually very good. Now, overall, the resective surgery, when we see across all the randomized trials, systematic reviews, pediatric systematic reviews, long-term studies, large cohorts, the overall seizure-free outcome is about 62% over long-term basis. Similarly, the complications, when we consider all the complications from 76 articles, about close to 6,000 patients, the rate of complication is very, very less. It's about 5%. Now, similarly, the quality of life, like Harry was mentioning, definitely is much more better in surgical as compared to medical, which is much more inferior. And the quality of life and memory is also much more better whenever the seizure outcome is better. Now, it is important to understand that when we do surgery, we are not doing it for withdrawing anti-epileptic drugs. The anti-epileptic drugs have to be continued in about 80% of the patients. So in about 22%, you could be successful in withdrawing the anti-epileptic medications, but that is not the purpose of epilepsy surgery. The purpose of epilepsy surgery is to make patient seizure free. And when we think of withdrawing drugs, we have to understand that what are the predictors of good outcome and what are the predictors of bad outcome. For instance, in temporal epilepsy, if it's a pure temporal lobe epilepsy, there's a good concordance between PET and SPECT. If you perform a large resection like a temporal lobectomy for hippocampal sclerosis rather than selective, these are the conditions where we will be more successful in withdrawing drugs rather than when we have the predictors of poor outcome when there is a residual hippocampus or it's a traumatic case or generalized tonic-clonic seizures or acute post-operative seizures, you have it. So these are the conditions. I think it's better not to withdraw the drugs. Similarly, it's very important to understand what are the predictors of good outcome for extratemporal. So if you don't have any focal spikes, if you have a focal cortical dysplasia type 1 or acute post-op seizures or parietal cortex, these are not the predictors of good outcome. What are the predictors of good outcome? Short duration of epilepsy, complete resection, type 2. Type 2 is a good outcome. Similarly, tubers, large single tuber plus craniocortexectomy, again are good outcomes. So in this case, perhaps yes, you can withdraw the anti-epileptic drugs. Similarly, I would not withdraw drugs in children with congenital anomalies with encephalopathy, multiple seizures, generalized tonic-clonic seizures. So the p-value is very high. We should not withdraw. Type 1 cortical dysplasias, I think these are one of the most treacherous lesions. So if you don't do a complete resection, patient may even have status post-operatively. So that is the reason you have to ensure a very wide resection in such areas, and I would not recommend you to taper off drugs in such cases. Or there is an ipsilateral EEG spiking, again this has a very high p-value. Or presence of normal MRI, when you are operating kids with normal MRI, again you should not think of withdrawing anti-epileptic drugs. Epilepsy more than 11-year durations, because as you know, the networks are dynamic. So the longer the duration, the more widespread is the networks of epilepsy. So concluding, epilepsy surgery definitely is the only option wherever we diagnose it as drug-resistant epilepsy. It's very important to look whether it's substrate positive or negative. And whenever there is a presence of a substrate, this is a high, it's a high probable candidate for epilepsy surgery. Presence of status and encephalopathy, especially for pediatrics, should be one of the reasons to do early surgery. If you have MRI negative, please understand that it is not a contraindication for epilepsy, because you have to refer the patient to a tertiary center. Please do not shy away from referring any patients if the MRI is negative, because if you refer it to a tertiary center, like one Dr. Harry Subianto has in Surabaya, they will repeat an MRI again, they will be able to pick up some subtle substrates, and again they will be able to convert this from an MRI negative into an MRI positive. Because repeat MRI can often pick up substrates, improvement of MRI resolution again can improve lesion pickup rates. Now, network concepts is changing the surgical strategies, because now we understand that when we think of focus, we think that it's only one area, it doesn't change over a period of time, it doesn't expand. But when we are thinking of networks, we are thinking of multiple areas, it can expand over a period of time, and it can change with a period of time, and it's dynamic. So using this logic, we are able to tackle the surgical strategies much more better. And finally, you have to remember that surgery is safe, effective, and the only option for drug-resistant epilepsy. So setting up the Center of Excellence for Epilepsy, has been a very satisfying thing, because I never thought we will be able to do so much of work. We were able to put our clinical footprints not only in various parts of India, but also other places like Indonesia. We have had very good rapport with Surabaya, and I'm so happy that Harry could come and spend time with us, and we hope to have this collaboration going on for a long time. And then I did the first HEMISPHEROTOMY in Malaysia, which was really very satisfying, and the patient is doing very well. And again, I've done a number of cases in Morocco, but unfortunately, because of this COVID, this time my trip got cancelled. And I would also like to thank all my research staff who have been fundamental in bringing up Center of Excellence for Epilepsy, the research paradigms. And I think change is the only thing which is constant. And I would encourage you to read this book about who moved my change, who moved my cheese, because that will help you to accept the change, what is happening. For instance, the COVID crisis, what we are seeing is again a change. So the people who will survive the COVID crisis are the people who are been able to adapt well to the change. And in this book, actually, there are they are living in a particular cheese station and suddenly the cheese runs out. So one mouse says that I'm afraid to go out, I will stay here and perhaps the cheese will come back. The other mouse takes a risk and then jumps, and it's very happy that it's taken the risk to search for new cheese. So basically, cheese here is a metaphor for change. And then it realizes a number of learning, number of insights which helps the mouse or the mice to learn better. And these are the two metaphors which I think are very, very relevant as of today. One is adapt to change quickly, because the quicker you let go of the old cheese, the sooner you can enjoy the new cheese. So I think that's very relevant for today. And whenever you're thinking of doing something new, always think that what you would do if you weren't afraid. If you're thinking of doing something new, don't think that what will happen if the patient develops a complication, what will people say. Don't think in that way. Think that what is that I would do if I weren't afraid, and then try to attain that goal. So thank you very much again for this opportunity, for being able to give this webinar. And I hope sometime in future we will soon meet each other physically. Thank you very much.